Good morning, good afternoon, good evening, everyone, and happy International Women's Day. On behalf of UNICEF, I would like to thank you for joining us today as we share the new global estimates on female genital mutilation. My name is Claudia Cappa, and I have the pleasure of working in the Division of Data, Analytics, Planning and Monitoring in UNICEF New York headquarters. Before we go into the topic of today's webinar, I just wanted to let you know that interpretation for this webinar in French is available. If you wish to use interpretation, you will need to click on the globe at the bottom of your screen and select the French language. I don't want to take too much time for the introduction because data will be the one doing the talking today. We are here today 8 years after the earlier release of the female genital mutilation estimates that UNICEF produced in 2016. And we are here to share the latest developments and the summary of what has happened to the practice of female genital mutilation since then. I have the pleasure of introducing first Vidya Ganesh, who is the Director of the Division of Data, Analytics, Planning and Monitoring in UNICEF, for some introductory remarks. Thank you, Vidya, and happy International Women's Day to you too.
Thank you, everybody. And we can't say enough number of times Happy International Women's Day. And it's something to celebrate, and it is also something to inspire us for greater improvements for women and addressing the inequities therein. So once again, on behalf of UNICEF, all of us on our team, thank you for joining us today. It's truly special, and also doubly special because we are talking about an important issue on International Women's Day, but with hope that we can make a difference. And even as we share the new global estimates on female genital mutilation, harmful practices like the female genital mutilation, as Claudia said, has been in existence for centuries, and it's recognized internationally as human rights violations. We have achieved a great deal of success in reducing the prevalence of this practice over the past few decades. So we do know what works, but of course, context matters. So in this report, we will see from the findings why it remains a concern and where it remains a concern, and remotivate us to address this problem. And this is where data helps. Data has a critical role in identifying where program has been achieved in as granularity as possible and where the issues still remain intractable. Data can help us understand which countries and where in the world that we are on track to reach the targets, global and national, and where acceleration is still required. And what are the opportunities that we have? As we learn about these new findings today, we should reflect what is happening, like I said, in the countries that are driving progress and therefore the driving, contributing to the global progress, and see what we can learn. It's really through mutual learning and support, solidarity, we can truly overcome this problem, and we can. Insights like this are possible, again, because of investment in data. We are not flying in the dark, particularly the reliable and statistically robust data, as methodologically as it may be difficult. And that's where I really applaud the teams and the countries that have embraced the difficulty of the measurement and come up with ways and means to produce robust data, because that provides credibility to what we are saying. That come from nationally representative household surveys. We're only able to perform this analysis because of the existence of household survey programs like the Demographic Health Survey and the UNICEF-sponsored multiple indicator cluster survey. I can't tell you how invaluable these are, and there is no good alternative to this if we want a good household level, reliable, robust data. Data have the power to mobilize action and transform lives in truly multiple ways and positive ways. They serve as the compass that we all much need in our lives to guide us, the organizations and the governments, to make the right investments at the right time and take the necessary actions. I really look forward to hearing what questions that the data raise for you, What is the curiosity that you have? What are your reflections that you have about the implications of these findings? And how would you enhance your own respective areas of work? I really hope that today's discussion on data and what evidence it is pointing you towards will once again allow us to recommit, and it serves as a call to action to accelerate progress, the much needed progress on ending female genital mutilation. I know together we can. So good luck to all of us. Thank you.
Thank you so much, Vidya, for your opening remarks. And now is the time to let the data speak. I'm very pleased to give the floor to Colleen Murray, who led the preparation of this report and has been working to provide the world with stories through numbers related to female genital mutilation over a number of years. Colleen, happy International Women's Day to you too, and the floor is yours.
Thank you, Claudia. And let me welcome everyone again, and we're excited to share with you today the results of this new report, Female Genital Mutilation, a Global Concern. As Claudia mentioned, this report is a 2024 update of a publication that was released in 2016, and we'll see that in the intervening years, there are some things that have changed and some things that have remained the same. We can share in the chat a link to the report and hope that you've been able to perhaps find it so far. Otherwise, we'll share the full report with you during this webinar. But for the moment, I'm going to go through some of the key findings of the report and guide us through by answering a couple of questions that the report answers for us today. So firstly, when we look at the data on female genital mutilation, one of the key questions that we want to answer is how common is the practice? We can answer this a couple of ways. First, by looking at how many girls and women are affected worldwide, and really get a sense of the toll of the number of people that this affects. We can also look at the prevalence of the practice, so see really how common it is in certain populations. So to look at the first of these, the burden of female genital mutilation, we see that today there are over 230 million girls and women worldwide who've undergone this practice. We see that the bulk of them, 144 million, are in Africa, with a further 80 million in Asia and about 6 million in the Middle East. We do have this today as a global estimate, and so it does include not only the countries where the practice is really deeply concentrated, but we do also estimate that there are between 1 and 2 million additional girls and women who've experienced FGM who live in small practicing communities and destination countries for migration in the rest of the world outside Africa, Asia, and the Middle East. So this kind of grand total number of 230 million, I think is worth noting, is 30 million higher than we had previously estimated 8 years ago. And we'll go into the reasons for that a bit, but one of the big reasons that we see for this increase is that while there is some progress in reducing the prevalence of FGM, it's not fast enough to keep up with population growth in these countries. So there are just simply more girls being born in these countries at a fast enough pace that it's really outpacing the progress. So with each passing year, we're seeing more and more girls who are affected. The other thing of concern that I'll note is that out of this 230 million girls and women, 1 in 4 of them live in fragile or conflict-affected countries. And we know that this makes programmatic approaches for preventing the practice and reaching these girls and women with support particularly difficult in this type of context. As I said, the other way that we look at understanding how common FGM is across countries is to look at the prevalence of the practice. Here I'm sharing a measure of prevalence of FGM, which is the indicator that we use for tracking progress towards the SDG target of eliminating this practice by 2030. It's the percentage of girls and women aged 15 to 49 who've undergone FGM, and really tells us sort of societally in each country how many, what share of girls and women are affected. We see that in the countries that have collected this nationally representative and internationally comparable data on the practice, of which there are about 31, we see that the highest levels are found in Somalia, Guinea, and Djibouti with 90% or higher. And then the levels really vary a fair bit across countries. So in some countries, we have really small isolated communities that are practicing, whereas in others, it's much more widespread. The next question that we tried to answer with the data in this report is to take a look at under what circumstances is FGM carried out. And there are a few angles that we want to look at here to help understand what really are these girls experiencing when we say that they've experienced FGM. So first, how old are they? How old are the girls who experience the practice? Is it carried out on girls who are babies, school age, adolescents? Also, what type of FGM do they experience? So we have these, again, kind of big picture numbers that tell us a large number of girls and women have experienced the practice, but what they experienced is not the same. It's not a universal experience across all 230 million of them. And then who performs the procedure? This question is, I think, important for us to think about, particularly when we want to think about programmatically, who are we addressing or who are we trying to reach when we think about trying to prevent the practice? Is this something that's carried out by medical personnel or traditional practitioners? So to answer these questions one by one, how old are girls when they experience the practice? This really varies across countries. We see that in some places, FGM is carried out in very young, so even in some places in the first days or months of life. In other places, it extends well into adolescence and is more of kind of this rite of passage into womanhood. We do see a really big bulk of the practice that's happening before age 5. So out of the 4 million girls who are cut each year, 2 million of them are cut before they turn 5. In terms of the type of FGM that is experienced, we see there is a lot of variety across countries. The most common type is cutting with the removal of flesh. But we do see, again, each year, over 500,000 girls experience the most severe form of FGM in which the genital area is sewn closed. And lastly, who performs the procedure? So in most countries, we see that traditional practitioners are responsible for the majority of FGM. However, we do find that medicalization is getting quite common, particularly in a number of countries where there is both a large population and a relatively high prevalence of the practice. And so a handful of countries where medicalization is common are really driving an overall trend in the number of girls who are cut by health personnel. So in total, 66% of girls are now cut by health personnel rather than traditional practitioners. This is a real shift here from the past where health personnel had contributed a much smaller portion to the overall practice. For each of these questions about the circumstances around FGM, I would direct you to take a look at the report and see, you can see data country by country, because the situation is actually quite different on a country by country basis. I'll show you an example of one of the 3 here so that you can see really how much variation we see in the circumstances in different places. So this chart here shows us the distribution of girls who have undergone FGM according to the type of practitioner who performed it. So for each country, we have this full distribution of girls who have experienced it, and we see what share of these girls were cut by health personnel, which is shown in the yellow bars, versus different types of traditional practitioners, which is shown by the blue share. And I think this finding is quite interesting here, actually, because we can see that across countries, right, most countries, there's a lot of blue in this chart, right? So this tells us that in most countries, the traditional practitioners really are carrying out the bulk of the practice. However, the portion that's shown in yellow, so this represents the FGM that's carried out by either doctors, which is quite common in Egypt, or nurses, midwives, and other health workers, which we see is more common in places like Sudan, Indonesia, and Guinea. This yellow portion of the bar together is what accounts for 66% of the cutting by health personnel. So there are so many girls and women that fall into the burden of the practice in these few countries that this portion, though it looks small here, really accounts for a large total number. So next we can take a look at answering the question, is the practice changing? We've already alluded to this a little bit about noting that there is progress, but not enough. But I think it's, again, worth looking at the data and take a look at what the situation is across countries, because when it comes to FGM, there's really almost no universal answer to any of these questions. It's incredibly contextual. One of the first and most important questions I think we want to answer about whether the practice is changing is it getting less common, and if so, where? When we want to answer this question, we look at the trend in the practice over time. And so the charts that we have here show us the percentage of adolescent girls 15 to 19 years old who've undergone FGM. And we look at what the levels were about 30 years ago and what the levels are today. Here, and I understand this is quite small, you can see these same charts in the report to zoom in a little bit and find the country that you're interested in. But what I want to emphasize here is that there are quite different patterns across countries in terms of whether progress has been achieved. On the left-hand side of this chart, we've grouped all of the countries that have really made the strongest progress in reducing prevalence of the practice. So these are countries where the prevalence has dropped by at least half or by at least 30 percentage points. So really big gains, again, over a pretty long time. This is over the course of 30 years. But there are a number of countries that fall into this category, from Sierra Leone, Burkina Faso, Ethiopia, Liberia, Maldives, and so on. There are a number of countries that have really achieved great progress. I think it's also worth pointing out here on the left-hand side in this chart that we see great examples of progress across the spectrum of prevalence. So it's not as if only those countries that have had traditionally low or moderate prevalence are those that have been able to achieve success. There are countries you can see who 30 years ago had from 10% to 95% prevalence that have all managed to bring down the prevalence. So I think it's really great that we can look to examples of success across the board. Moving on, there are other countries where there has been less progress. So in this middle category, we see there's a group of countries where there are declines, but they're slower. There's been less of a decline over this course of 30 years or so. And these are countries where the levels are, still quite high, or we have been traditionally quite high and are starting to see a decline. So we see like Egypt and Djibouti would fall into that category, for instance, where the levels had been practically universal and really now are starting to come down. And then in the last category, we see that there are a handful of countries with no evidence of progress over several decades. Again, kind of interesting to see that this is not only the countries where there's nearly universal prevalence, like Somalia, for example. We also see countries like Mali, Guinea-Bissau, and Senegal, where there are certain practicing communities within these countries that don't take up the entire population of the country, but the ones that do practice it consistently over time. In looking at trends, I wanted to follow up with two details here, I think, that can shed a little bit more light on what's happening. The first is to zoom in for a moment on the experience of Kenya, which is profiled in the report. We can see Kenya was in that first column of the countries that had achieved the greatest progress over the past 30 years. We wanted to take a look at what does that look like within a country. I think the prevalence overall had dropped from around 25% to a little less than 10% over the course of about 30 years. And here we look back even a little bit further to about the 70s. And we can see that in the past, FGM was practiced in nearly all of the country. to a greater or lesser extent. And as time moved on, the practice was slowly abandoned, kind of geographically region by region, leaving only the northeastern province as the one where the practice is really still quite concentrated. And we can look at this same time period in a different way by looking at the prevalence among different ethnic groups in Kenya and seeing which ethnic groups have abandoned the practice and which have held on. And what's clear here is that the Somali group within Kenya, which of course is also the one who lives primarily in the northeastern province, is the both this is the ethnic group and the region of the country where there is some incredible resistance to abandoning the practice. So while other regions and other populations within the country have really seen these dramatic declines over the course of the last several decades, there is kind of a holdout in this part of the country. And what we've seen is that, again, there will only be a certain level of prevalence that the country can get down to with the rest of the country abandoning the practice. Eventually, the practice is left in these pockets of resistance here, and no further progress will be possible without addressing this population. The other point that I wanted to supplement here with on trends is to illustrate a little bit more this point of why do we see that the practice is becoming less common when we look at prevalence, but more common when we look at the total number affected, right? How do we see this increase from 200 million girls and women to 230? Well, there are no countries where the practice is getting more common. I had mentioned earlier that this is due to population changes and wanted to illustrate that a little bit more clearly here. So the countries where FGM is concentrated are countries that already have seen quite a rapidly growing population and are projected to continue seeing a rapidly growing population. So in the half century from 2000 to 2050, we can see that the countries in which FGM is concentrated have and are projected to see a 62% increase in the number of births of girls each year, even as the rest of the world is not experiencing this type of population growth. It's actually declining. Of additional concern is that of this 62% increase that we see in the countries where FGM is practiced, the greatest increase that we're seeing, the greatest proportional increase, is in the countries that are affected by conflict and by fragility. So these places that are the most difficult to address are the ones where the problem is projected to grow if these types of trends continue. So to conclude here, the last section that we want to look at is to try to understand is the elimination of FGM within reach. Again, we know we have this target of eliminating the practice by 2030. What can the data tell us about whether we are on track or not on track to meet this target? So the 2030 target, I think we can start by saying is it was always an ambitious target from the time that it was set. And it was set kind of in the principle that no level of FGM is acceptable, and so no target other than 0 would be appropriate. What we see when we see progress over time is that, again, there is some decline. This chart here shows us the trend in prevalence in the countries that are making any progress at all. So it excludes the ones that have had the flat line over time. But even in the countries where we're making progress, this rate of change over the past 30 years or so is modest compared to what would be needed in order to reach the 2030 target. So projecting these levels forward, we again, if we see in the future what we've seen in the past, the levels would continue to decline modestly. If we were to reach the 2030 target, it would require an acceleration of 27 times faster progress to meet the target. So it's a real, call to action that the efforts that we've seen to date have not been sufficient to meet the target that we set out. Again, this message is one where we have an answer at the global, kind of global aggregate level. At the aggregate level, progress would need to be 27 times faster. At the individual country level, the situation is quite different across countries, as you might imagine. So I would direct you to take a look at the report, because again, this is a bit small to see each of the country examples, but we can kind of go through this gradient to see what's the situation of each country in terms of their progress that would be needed to meet the 2030 target. There are a handful of countries where the target has been achieved before 2030. So the current national prevalence, we define it as less than 1%, just for statistical purposes, but effectively the target has been reached in countries like Cameroon, Ghana, and Uganda. A few others are on track to reach the target before 2030, so they're not quite beneath that threshold yet, but if the current rates continue, they would reach the target before 2030, and this includes Benin, Togo, Niger, and Maldives. The rest of the countries would require some acceleration. So in some cases, we need a little bit of acceleration, right? So we have countries like Iraq, Nigeria, and Tanzania, where about a 2 times faster rate would bend the curve enough for them to meet the target by 2030. And as we go further down this line across the top of the screen and then into the bottom row of the screen, we can see this illustration of the blue line is showing us how much do we need to bend the curve in each of these countries in order to get to that 2030 target. So there are additional countries that would need to progress at a rate that's 10 times faster, 20 times faster in places like Djibouti, Mauritania, Sudan, even 100 times faster, right? So a real bend of the curve. And then this last group of countries where, again, we've not seen progress in about 5 countries. And for those, it's they would need to first really overcome the stagnation of a flat line to even start bending the curve. So I think that overall, when we look at progress here in relation to the 2030 target, we certainly have mixed results. There are countries where we see reasons to celebrate, and many others where the progress is just not sufficient, and many girls remain at risk. So this concludes the presentation of the data. Again, there are some more results in the report, so we can put in the chat a link so that you can review in more detail. If you'd like to access the report or learn more about FGM data, we've also put the link here to the UNICEF data website. Thank you, and back over to Claudia.
Thank you so much, Colleen, for the presentation, and there was a very lively Q&A chat, so I'm gonna go over some of the questions already that we have here. So first of all, let me start with Zeynep. Zeynep is sharing, I'm a clinical psychologist working in Turkey, continuing my research on FGM. However, I cannot find any significant data for Turkey, even though it's well known that is practiced by Kurdish Shafi minority. Any suggestions, Colleen?
Thank you, Claudia. So there are, yes, so understanding that this is the situation in Turkey, there are also a number of other countries where we know that the practice occurs in small minority populations throughout the country. There is a fair bit of research that identifies the number of communities where this is the case. We can also, I think, share a link to an article that actually Claudia had written that summarizes the state of the evidence on countries outside the ones that collect nationally representative data. Again, in some cases, it really is small communities. And so if there are quite small communities that are practicing, we would not expect that they may ever, take up a national level data collection on this topic, because it would not be the right use of data resources to collect data on an entire country just to target what's happening in a small community. So in some cases, these small scale studies really are the appropriate way to track what's happening. We can follow up by sending you the link to that. I'm not sure whether Turkey is covered, but I think that it may be covered in there. Over.
Thank you, Colleen. And along the same lines, Zeynep is asking why India doesn't exist in the chart.
For the same reason. So, so in the detailed charts in the publication, we are able to show data on the current prevalence, the trends over time, the circumstances under which it's carried out, people's attitudes towards the practice, which we didn't even cover here. We're able to do those because national authorities have decided to collect nationally representative data on these topics. That is the case for 31 countries, but there are additional countries where we know FGM is practiced but have not taken up data collection. So what we know about those, again, comes from research, but we can't formulate that data in a way that's comparable to the other countries and show it all together like a comparable package of information.
Thank you so much, Colleen. And now there is a question from Workinet, who is from the Ethiopian Statistical Service, who conducted EHS. So I just want to add my personal thank you, Workinet, because it's thanks to the work of people like you in the EHS surveys, in mixed surveys, in other national surveys, that we are able to have a sense of how widespread the practice, because the data that we use comes from demographic and health survey as well as from mixed survey. So Workinet is saying, I can see from your presentation that Ethiopia shows strong progress in reducing FGM, which is a great news since we are working on the issue across the country. But my question is, how did you collect the data? What is your source? Because we are about to conduct a DHS that contains an FGM module. So Colleen, over to you.
Thank you. So again, as Claudia said, thank you to you for collecting the DHS data, because that is how the trends are assessed. You may notice that we are looking at trends over at least 30 years. When we saw the example for Kenya, you saw we went back even further than 30 years. We're able, and that often is longer than the period that DHSs have been conducted in a given country. We're able to do that because when you all collect data on FGM in something like a household survey, information is collected from girls and women of different ages. And we know, as we saw from the findings on age at cutting, often FGM occurs among girls who are quite young. So it may happen when girls are 5 years old or so. Then we continue to ask girls and women questions about their FGM status when they are 15 and 20 and 30 and 40. Their FGM status is not changing, right? Once it's determined in their childhood. So when we look at the prevalence of FGM among girls who are teenagers, it's often representing cutting that happened a few years ago, maybe many years ago. And particularly when we look at the prevalence among women who are in their 30s and their 40s, this is representing levels of FGM that occurred in the population decades earlier, when these women were young children. And so because the way the data is set up that way, it really helps us to be able to use that information on what older women tell us to look into the past, right? And to see what were the prevailing levels at the time that these women were cut. And so that's why we can use something like household survey data to look at longer term trends. I hope that's useful.
Thank you, Colleen. Alessia is asking, is there data on who decides whether to perform FGM on the girl?
Thank you, Alessia. In some countries, this information is collected. I think, if I'm not wrong, I think actually Ethiopia was one of the countries that did collect data like this. Over time, there have been some national surveys that have included additional information like this. So I think the core type of information that we see collected is about whether someone experienced the practice, and the same thing about their daughters. So did they experience it? Yes or no? What type of FGM did they experience? At what age was it done? Who was the person who did it to them? And then what did they think about the practice? Should it continue or stop? In some cases, there are additional questions, like, for example, whether they think the practice is required by religion, whether they think what they think the benefits to the practice are for the girl, right? Do they think that it maintains their purity and chastity? Do they think it will, be a requirement to help them be able to get married, for instance, things like that. And this one about who decides about the FGM is one that's been included less often. So we do have some results, but not universal results across all the countries.
Also, because if I may add to this is a complex question and difficult to answer through this type of questionnaire. So this type of data collection is really not suitable for understanding the reason why people act in a certain way. But we know that this decision-making process very often involve a few people. Sometimes there is not such a decision because there is not necessarily a discussion. It's something that people carry forward because that's the expectations that they would do so. That's something that this type of understanding and literature and evidence is best collected through qualitative type of surveys and study that allow you to really understand some of the dynamics that might occur around the practicing of FGM. Stephanie is asking, hi Stephanie, with girls increasingly undergoing FGM at younger ages, will that have implications on reporting the practice in mixed and DHS surveys?
Thank you, Stephanie. It's a good question. So what we've seen is that we, in the standard modules for collecting data on FGM, we often ask, at what age was FGM performed? And this can be recorded in different ways depending on what we expect the answer to be. So if it's, performed in, early ages, middle ages, later ages, we can just ask the year and kind of like, how old were you? How many years old were you or was your daughter when this happened? And we can see that distribution. In other countries where we know that it is done very early in life, for instance, we might ask the age by asking how many days old were they, right? So then we can capture things like, did it happen in the first day, in the first week, in the first month? And so when countries are collecting data on FGM, they will customize the answer options like that so they can get the appropriate level of detail. This has been done in countries like Mauritania, for instance, where it's performed quite early so that you don't end up with all the answers, kind of lumped into a 0 to 4 years old category without knowing that actually it's not, happening among toddlers, it's happening among newborn infants. Over.
Thank you. Jean is asking, is there any evidence of a connection between FGM and sexual exploitation of children?
Good question, Jean. I will pass to Claudia perhaps to pick up on that one. Please go ahead.
Thank you, Colleen. Jean, there is no such a thing in terms of data or evidence that we are aware of or that we have produced, for example, that establish an association between FGM and sexual exploitation of children. This is the first time I actually hear of a possible association. There is nothing I'm aware of in terms of evidence that currently exists that is in our possession. Thank you. Julita is commenting, hi Julita, nice to see you. A great presentation, asking the right questions, and the data is definitely doing the talking. Did you say there is no countries where the prevalence has increased? Also, do we have data for Malaysia?
Thank you, Julita. That's correct. There are no countries where the prevalence has increased. Again, to kind of separate these issues, there are countries where the number of girls being cut has increased, and this is a really important consideration. But in terms of the prevalence, the share who have experienced FGM, we do not see any places where there has been an increase. There is not evidence that communities who have not traditionally practiced FGM are all of a sudden picking it up. So no, we don't see that. And Malaysia, no, has not collected nationally representative data on FGM, though this is one of the countries where there is a fair bit of evidence that indicates that the practice is performed among quite decently sized share of the population.
One thing I want to add to this type of data that we are talking about and we are using here are population level data. So they are meant to give you a sense of how widespread the practice is at the level of a population. Now, when we say that we don't have evidence from this data that the prevalence of the practice has increased, it does not mean that you might not have cases where, for example, there have been a few numbers here and there that have increased, but also that the risk has increased. It's in a way that is really not being able to pick up in this population level data collection, which is also based on samples. And when you do this type of estimation work, which is necessary for a number of technical reasons, you do not have an extremely precise count. So you have a population level account, right, which has to be accurate, but cannot be precise at the level of individual girls. Yeah. We have Mariam who is saying, hi, I'm a medical doctor from Somalia. Nice to meet you, Mariam. I noticed that there is no data about who performs FGM from Somalia. No data, thought we noticed an increase in the medicalization.
Thank you for sharing this. So there is an increase overall in medicalization when we talk about all of the girls and women who have been cut in all of the countries where it's practiced. But it's, I think, really important to consider that this is not the case in all countries. There are some countries where traditional practitioners still perform 95% or more of the practice. In Somalia in particular, it's true we don't have the data included. And honestly, it's because there are some data quality issues in the collection of FGM data in recent years. So we didn't have an estimate of sufficient quality that we could include for that chart. We can perhaps get back to you bilaterally to give some more details on what we've seen kind of in general in the evidence, to give you a bit more detail about that, but it wasn't able to make it into the report, unfortunately.
And this gives me a chance to, in a way, mention an important element related to the way these data are compiled by UNICEF. Because these are data that are not collected by UNICEF. These are collected by national statistical authorities in the different countries where FGM is concentrated. It's the National Statistical Authority and the government of the country that run this data collection effort. They are part of official statistics. They are decided at the country level. They are implemented at the country level. So as UNICEF is the custodian agency for monitoring or supporting the monitoring of the SDG 5.3 related to female genital mutilation, it's our responsibility to compile this data from the different SDG focal points in the country. In this process of compiling this data, we receive different surveys, we receive the tables, we receive the data sets, and we conduct an overview, a review of these databases and the questionnaire to ensure that the questionnaire and the data that are submitted comply with the requirements for global reporting, which has to do with coverage, for example, reliability, also comparability of the estimate, etc. So just to say that, again, it's very important that we make this distinction because we need to recognize the important role that is played by national statistical authorities and government entities within the countries that conduct this survey. Having said that, these surveys are done according to very strict protocols and procedures to ensure data quality. Women are interviewed in individual places. There is, of course, there is always the possibility that women who are exposed to campaigns or discussion about FGM might feel a bit resistant to disclose their status, but technique and good training when conducting this interview facilitate the disclosure of the information. And along this line, I want to respond to WorkInEd, who is asking whether there is a standard questionnaire for collecting these questions in DHS. Yes, indeed, there is a standard questionnaire that has been developed and tested and validated, has been used in many countries across the world to collect this information. It's part of the DHS set of standard questionnaires, version 8, and we will be happy to put in the Q&A in response to your question working at the link where you will be able to download the questionnaire that is being used. Using a validated questionnaire to ask this question is critical because small changes to the formulation of the question or the use of a different word can have a tremendous impact on the quality of the data. So we spend years sometimes testing this question to minimize data quality issues such as response bias, for example, or to minimize the risk of compromising comparability over time or across countries. So a couple of more questions, and then we are going to have to move on and give the floor to our last speaker. So Arunav is asking, when you show 66% of girls who are now cut by health personnel, is that 66 from the 30 million new estimate?
Thank you, Arnav. Not exactly, I'd say. So the 30 million additional girls and women who've undergone FGM since the estimate 8 years ago is mostly due to population increase, not an exact addition of there have been exactly 30 million new cases, right, since the last estimate. What we do see is that there are about 4 million girls who are cut each year. And in the recent years where FGM has been performed, so in the last, I would say last 5 years or so, this is about an average of the last 5 years, the share who have been cut by health personnel is 66%. So it's the current share of girls who are cut, this year, the year before that. It's not an exact correlate of that 30 million addition.
Thank you, Colleen. Is there a correlation between FGM and conflict?
Thank you. So what we've shared in this analysis in the report is that there are a lot of girls and women, 4 in 10 of those who have experienced FGM worldwide live in countries that are affected by conflict or fragility. So there's that means that there's a lot of overlap between the countries where FGM is practiced and the countries where conflict is ongoing. That said, we are not showing that there is an association between conflict and FGM. We're not saying that conflict causes FGM, that conflict makes FGM more likely, that it makes it worse. And actually, when we look at the data, we don't see that the levels of FGM in places of conflict are higher, right? They're quite comparable. We don't see that, when conflict starts, FGM becomes more common. So none of that. So I think that's an important thing to distinguish here. We're not talking about there being a close association between these two things that's related to one another. What we're saying is simply that these are things that coexist, and it makes, I think, addressing the issue quite difficult because of the conditions that are imposed by conflict and fragility.
Thank you, Colleen. And there are 3 last questions, and I want to go read them to you in the hope that you can address them. We have about 5 minutes before we give the floor to Shima. So the first question, is there any more you can share about regional trends in Southeast Asia on FGM, Indonesia, but also other countries? Then we have Trianta Philos is asking, hi, do you confirm that religious reasons aren't prevalent? And then I said there were 3 questions, but in the meantime, they become 5. So let me read them quickly for you, Colleen. How does UNICEF deal with the accuracy of the self-report system of FGM prevalence rate data collection? Does the questionnaire methodology of data collection vary depending on the cultural or social circumstances in each country? Can we share this aggregated data by education, rural, urban, for example?
Okay, These are all excellent questions, and I will not be able to give them all the time that they deserve in the 4 minutes left before we hand over, but I'll do my best. So, oh, and now they've disappeared on my screen. So let me try to see them from memory. Okay, in Southeast Asia, so we have this of the global number of 230 million who've experienced FGM, we see that 80 million of those are in Asia. There is a very small number that's estimated in the Maldives. Most of the rest of that is in Southeast Asia. Of the countries in Southeast Asia, Indonesia is the only one that has collected nationally representative data on the practice. They've collected data twice now, in 2013 and 2021, and those have both shown that about half of girls and women in Indonesia experience FGM. So that's essentially what we know about the practice there. There are, again, other countries where there's a fair bit of evidence that is showing that the practice exists but have not yet collected data. So we would hope to eventually be able to learn more if these national authorities could be convinced to collect data on this important topic. In terms of whether there are religious reasons, we do have information on this. It's not featured in this report, but there are a number of countries that have collected data on whether people feel that the practice is required by religion. Often people do think that the practice is required by their religion. I think this is a common area for intervention, is working with the religious authorities to encourage some reflection on the fact that FGM is, not promoted in any religious text or sanctioned by any of the major religions, but yet people still do indicate and feel that it is required by their religion in many cases. And
there
then
was a question, Colleen,
self-report.
about, yes, the self-report and whether the methodology changed depending on the culture of the context.
Thanks. Okay. So for self-report, so what we've found over time is that women are usually quite willing to disclose their FGM status, especially in places where it is a practice that is widespread within their community, right? They themselves are cut, everyone they know is cut. It's an important part of their cultural heritage. They are often not slow to disclose that it's been their experience as well. Particularly, we can see this among older women who maybe have been cut a very long time ago. Even if they may have been exposed to some awareness campaigns or some advocacy against the practice, they might be aware of legislation. Often for the women who experienced the practice a while ago, they still, for them it's something that happened in the past. And so they may be less likely to disclose what they're planning to do for their daughters, but for themselves, they often are willing to disclose it. We have seen some evidence now coming up in a number of countries where where we can tell from the data that in certain data collection exercises that people are less likely to disclose their status. And we can tell that by comparing, how people answered, one time versus in another data collection exercise. We can tell if there's underreporting, and it has been the case. It's definitely an area of concern, particularly because we are often really wanting to look at, what's happening among the youngest girls, and that may be where people are the least likely to disclose that they have cut their daughters or intending to cut their daughters, because it's something that's happening more right now in the moment, and they may really feel the pressure to shield that information, and it's a concern in some places from a data quality perspective. In terms of whether the questions are changed for different social and cultural concerns, the big change that we would see is a customization on a country by country basis in terms of what the practice might be called, right? In some places, it will be called circumcision. In some places, it will be called excision. In some places, right, there may be different words that are used locally. So we would certainly want some customization so that people know what you're talking about and you call it the same thing that they themselves call it. There also may be some customization a little bit about what type is performed if we know from other evidence that there are types beyond the few that are in the standard questionnaire that are really commonly practiced. Aside from that, as Claudia said, really the standard questionnaire really covers a lot of bases and is well understood pretty broadly. So the types of customizations that should be done on a country-by-country basis are pretty small.
Thank you, Colleen. And then there is just a quick answer I want to provide to those who ask whether this data is available or this analysis by place of residence, education, well quantile. Yes, we have this data. We have not included everything we have in our databases in this publication because we wanted to pick up a few stories. Over the last few years, we have been published on FGM every year. Every year there is a report. Every year there is an updated database, because this is part of the role that we have as custodian agency. So we choose a topic for every year brochure, and this is obviously the global estimates that we plan to reproduce every 4 years. We skipped 2020 because COVID was there and a lot of data collection stopped, but we plan to reproduce this estimate again every 4 years. But please do look for UNICEF updates every year. In the first trimester of the year, we always release something new on FGM, and we update our databases. Now, thank you so much, Colleen. It's time to give the floor to our last speaker. I am delighted to introduce Shima Sengupta, who is UNICEF Director for Child Protection in UNICEF headquarters in New York. Happy Women's Day, Shima, and thank you so much for joining us. The last words are with you. Thank you.
Thank you so much, Claudia. And actually, I do want to start with that. Happy Women's Day. But, you know, really for everybody in the room here, in this virtual room, to say a big salute for the courage with which everyone continues to work in this field, which is so sensitive, so difficult, and yet really, really essential for us to ensure that we do actually continue and that we forge on. Extremely important. So I've been listening in on the questions as well and looked at the data. Very interesting questions. And again, you know, the questions also give me a sense of hope for where we can take this and how we can intervene. So, ladies and gentlemen, thank you all for joining us today in this launch, which is on critical estimates on female genital mutilation. As we stand at the crossroads between the progress made on the SDGs and the challenges ahead in shaping the post-2030 agenda, this discussion couldn't be more timely, especially with the imminent Summit of the Future on the horizon. Friends and colleagues in this field, as you have heard this morning, the data has spoken. It's time for us to confront the stark reality before us with a sense of urgency and determination. And this is why I salute all of you, because I do know that in this virtual room of ours, there is that sense of urgency and that sense of determination to see this through. FGM continues to persist as a violation of human rights, casting a long shadow of gender inequality and, of course, endangering countless lives. In the face of mounting resistance to the rights of women and girls, our commitment to their welfare becomes more than a moral imperative. It actually becomes a rallying cry for justice and equality. And, you know, the last 12 months, we have seen how in many of the countries that we work in many of the countries where we see FGM prevalence, that things look as though they may be regressing. I'm not speaking about the data. I'm speaking about, you know, normative frameworks, regulations, and so on. So I'm extremely concerned, and yet I'm hopeful that as we confront this challenge head on, Why am I concerned? Concerned because despite our efforts, the data presented today shows that progress in ending FGM has not kept pace with a growing number of vulnerable girls entering the world. Yet, amidst these challenges, hope persists. The data speaks volumes. Some countries with entrenched FGM practices we have seen have made remarkable strides towards ending this harmful practice. Some are even on track to meet the ambitious SDG target of eradicating FGM by 2030. So, ladies and gentlemen, the time for action is now. We must redouble our efforts, channeling resources towards essential services, empowering girls to claim their rights and shape their destinies. Governments must prioritize the enactment and enforcement of laws that safeguard the rights of women and girls, providing robust protection against FGM and other forms of gender-based violence. And let us not forget the power of accurate data. It serves as our guiding compass in this journey towards equality and justice. As we conclude, let's remember that FGM is not an isolated issue, but it's a symptom of broader gender inequities that plague our society. Our commitment today lays the foundation for a safer, healthier, and a more just world for this generation and those yet to come. Let us march forward with unwavering resolve, knowing that our actions today will shape the future of millions of women and girls worldwide. Thank you.
Thank you, everyone. Bye-bye. Thank you, Shima.
Thank you all.